and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to the B-Scan course, Part 3. In the Part 3 of this B-Scan course series, we will be studying and learning the various B-Scan reports with examples. And we will be now applying what we have learned in the Part 1 and Part 2 videos of the B-Scan course. Now let us start with the abnormalities in the coats of the eye. We know that we normally have a retina, choroid and sclera, and these three things together will form the coat of the eye. The coats are normally present together, and in a normal eye with a normal axial length, they will look somewhat spherical in shape. However, we can see in the first B-scan over here that there is an elongation, and along with the elongation you can see near the optic nerve shadow, we can see that the retina and choroid and sclera complex, or the coats or the eyeball itself, seems to be pushed behind, right? So this is nothing but the posterior elongation of the eye, which is nothing but the STAPHYLOMA. However, we can still see all the spikes which are coming from the retina and the choroid and sclera. So what I mean to say is all the three layers are still present, just that the eyeball itself is more prolonged or lengthened in size and shape. Now let us consider the second picture. In the second picture, however, you can see that till this level the retina is present, the choroid is present and the sclera is present. However, from here we see that there is an excavation in the retinal, choroid and sclera complex, and such an excavation where the layers are actually absent. Okay, either the retina and the choroid is absent in this case and the sclera is present, right? So you can actually make out that these three layers are not continuous here, right? They are absent and there's an excavation, and this is nothing but this is the coloboma of the retina choroid, right? So in STAPHYLOMA there is just a prolongation, but the layers will still be present. However, in coloboma the layers are also absent, and rather than prolongation it looks like excavation. Next, we are going to talk about some of the vitreous opacities which we see in a B-scan. Now, normally in a normal vitreous, we can see here it looks totally dark in color, and there will be no echoes found in a normal vitreous, right? In a normal healthy vitreous. So such a vitreous is called the echo-free vitreous cavity, right? And which is normal vitreous cavity. Now let us have a look at the second picture. Here in the second picture we can see that few dot-like and clump-like opacities are actually seen in the vitreous. The vitreous is not that echo-free, right? And this is a picture of vitreous syneresis, right? So in vitreous syneresis what happens is that the gel component of the vitreous will clump together and separate from the liquefied part of the vitreous. So because of that clumping and separation of the gel component from the liquid component, or in simpler words you can say vitreous liquefaction, these small cells like or dot echoes will actually indicate vitreous syneresis or vitreous degeneration. One more thing about this vitreous syneresis or vitreous degeneration, what I want to tell you is that these echo dots will have extremely low reflectivity if you see on B-scan, right? Almost about 2 to 20% only will be the reflectivity. So in such a case, in order to appreciate them, maybe you would have to increase the gain by about say 5% to 6 decibels, right? 5 to 6 decibels you have to increase the gain in order to see such very low reflective echo dots representing the vitreous degeneration. Next, what we have is the vitreous hemorrhage. Now, the vitreous hemorrhage could be actually, three types. The first type could be a fresh VH or the fresh vitreous hemorrhage, or it could be a resolving vitreous hemorrhage, okay, resolving VH, or it could be actually organized vitreous hemorrhage, right? So, organized vitreous hemorrhage means that with time, the cells which are diffused, that is the red blood cells which are present in the blood, they are going to get clumped together, and as they come together they will form a membrane. Okay, so this is called organization of the VH, and subsequently as they form membranes, these membranes, as we know, all the membranes, they have this ability to contract, right? So if this one of these membranes goes and attaches to our retina, and as they contract, they can actually cause traction on the retina, and then they can cause RD also. And that is the reason in any non-resolving vitreous hemorrhage we have to go for a vitrectomy. Now, this picture over here, that is the second picture over here, we can see multiple fine dot-like echoes, right? And these are very fine. You know, if you notice them and compare them from vitreous degeneration that we saw, vitreous degeneration was still irregular. They were not very homogeneous and they were a little bit bigger compared to this fresh vitreous hemorrhage echoes that you see over here. So they are so fine that you can actually call them as dusting. Okay, you can call them as dust particles. So this is called a dusting of the vitreous body that we see in the case of the fresh vitreous hemorrhage. Okay, and usually they will be so small that you cannot actually pick them on a normal gain setting. You might actually have to increase the gain by 10 decibels also in order to make them more clearer. Okay, similarly you can see in this picture also, this is also a fresh vitreous hemorrhage, and just look at the reflective echoes which this vitreous is giving. It is so tiny, it is so less, right? You can see they're almost near the baseline, whereas this retina and choroid are so high, right? So so in a fresh case of fresh vitreous hemorrhage, the echoes will be multiple, but they will be very fine echoes, opacities, and they will look like dusting, as if they are dusting the vitreous body. And to see them properly, you will have to increase the gain by at least 10 decibels. And their reflectivity also will be very less, you know, almost the reflectivity will be about 5 to 10% only. Now this is again same this is again a picture which is showing vitreous hemorrhage, and as you can see in this also we can say widespread dots are present, right? And this picture is looking very whitish to you, right? So this is a picture in which the gain has been actually increased, right? So that we can see the vitreous hemorrhage more clearly. Right, this is showing low intensity echoes in the vitreous chamber. And one more thing is that, as I told you in the kinetic kind of B scan or the dynamic B scan, which I told you about in my second part on the B scan course, anything present in the vitreous, you know, it will show movement. Okay, it will have movement. So even vitreous hemorrhage, with the movement of the eyeball, the vitreous hemorrhage will also show after movement. Now similarly, this is the picture in which there's a fresh vitreous hemorrhage. So all these dots over here, you know, they look very similar to each other. They're homogeneous and they're very fine. It's as if they're looking like dust particles, low reflectivity on low gain. Okay, and this is a fresh vitreous hemorrhage bleed. Now as the time passes, this fresh vitreous hemorrhage bleed has started now to organize. So now what we see is vitreous hemorrhage with these cystic spaces or lacunae. Okay, and here this is the part where clumps of cells are present. So this is a little bit more organized vitreous hemorrhage. Now as the time passes and vitreous hemorrhage starts resolving, now what we will have is that this vitreous dot echoes, which were very low reflectivity of about 5 to 10, will now clump together, and these dots will become more denser and the reflectivity will also increase. So as can be seen over here in this, that all the cells have clumped together. So this is like clumped vitreous hemorrhage and organized into membranes also. And just look at the spike. Right, these are low spikes, and here this spike is coming more, right? This shows that these echo dots have come together and now they are causing more or giving a more echo. That means this is a resolving vitreous or a vitreous vitreous hemorrhage which it has started to organize, right? So here the reflectivity might go up to about 60% also, right? Sometimes what happens is that in a case where we have old long-standing vitreous hemorrhage, the vitreous hemorrhage will actually form a membrane close to the retina and look as if it is a retinal detachment. So, and even an old vitreous hemorrhage can look like RD, right? So, but in that case, you have to know how to differentiate it from RD, right? So in an old vitreous hemorrhage which looks like RD, number one point to differentiate it from RD is that the reflectivity all throughout will be actually different. However, in case of an RD, the reflectivity will be equal. Okay, so it will be of equal reflectivity or equal brightness all along an RD. However, the vitreous hemorrhage membrane will have variable reflectivity. Moreover, you will see certain clumps and dot echoes in the vitreous which will tell you that okay, fine, this is actually a case of vitreous hemorrhage, and what we are seeing might be just a stained PVD, okay, a vitreous detachment on which cells have come and sat now, so that we are seeing it as a greater reflectivity area. Okay, yeah. but as such it is not a retinal detachment. Now these pictures over here also show how they can actually get organized into membranes like this. Okay, so they can actually look like PVD also, but you can see that here this PVD is only till here, it is not extending beyond, right? And they have organized into membranes as can be seen, and between there are some cystic spaces also. So such a type of vitreous hemorrhage can also be called as the gel hemorrhage, right? It can also be called as gel hemorrhage. Gel hemorrhage is nothing but when the vitreous cavity, we know that it is when there is SYNERESIS, there is liquefaction of the vitreous. So part of the vitreous will be in the gel form and part is liquefied, right? So whenever there is liquefaction of the vitreous, in that we will see diffuse vitreous hemorrhage, whereas whenever the vitreous is present in the gel form, the gel part will be occupying the part of the vitreous cavity, and the part which is available for the blood to enter, that will show the vitreous hemorrhage. That is the reason in a case of vitrectomized eye, when the eye has undergone vitrectomy and there is no vitreous and the vitreous cavity is totally empty, and then there's a vitreous hemorrhage, you will see a diffuse vitreous hemorrhage. Now these two pictures over here show us what a chronic vitreous hemorrhage will look like on a B scan. Just look at it, how bright the signal is and how clumped this echo dots are. Similarly here it is actually the clumped echoes which are coming from the vitreous, and over here is the PVD, right? So most of the time this vitreous hemorrhage, it tends to settle down because of the gravity, and therefore we are seeing it in the inferior part of our scan. Now at times these vitreous membranes can actually become very thick, especially in case of recurrent hemorrhage, and then they can get attached to the retina and exert a tractional force on the retina, resulting in a tractional RD, right? So this is usually seen in case of PDRs, that is proliferative diabetic retinopathy, in which they can have multiple recurrent hemorrhages. Then people who are hypertensive, they can have hemorrhages. Sickle cell disease, Eales disease, they can have recurrent vitreous hemorrhage which can form membrane, and then they can cause tractional RD. Now this picture over here shows us the subhyaloid. It shows us the subhyaloid hemorrhage, right, in a patient who is actually diabetic. So you can see that this is the PVD, that is a posterior vitreous detachment, and from below the PVD and in front of the retina is a subhyaloid space, right? And in that subhyaloid space we can see that the same dot echoes, very fine dot echoes, are present of low reflectivity, and these dot echoes which are present in the subhyaloid space is nothing but the subhyaloid hemorrhage. Now one differentiating point from subhyaloid hemorrhage from the vitreous hemorrhage is that the vitreous hemorrhage can get organized into membranes and clumps and form membranes, okay, and cause traction membranes also. However, a subhyaloid hemorrhage always it always will be in the dot forms only, and it always remains diffuse. It does not have a tendency to clot, or it does not have a tendency to get organized, and therefore always the subhyaloid hemorrhage will look like this, right? Now in the previous photo also which I showed you over here, this was our vitreous hemorrhage, and also because it is present in the gel, it is looking like that, and below that is, at this point, is the subhyaloid hemorrhage. The next type of vitreous opacities are the opacities which are actually present in inflammation of the vitreous, or vitritis. Okay, and these cells are nothing but the vitreous cells or the inflammatory cells. Now in vitritis, the inflammatory cells are going to look very similar to that of our vitreous hemorrhage, right? So there will be multiple scattered and diffusely located, or sometimes they can be actually localized into the anterior part, or into the mid vitreous cavity, or into the posterior vitreous cavity, depending upon the etiology. So what I mean to say is, if it is pars planitis, it might be in the anterior and the middle portion of the vitreous cavity, or if it is a posterior uveitis case in which we have toxoplasma or something like that, and so there the vitreous cells might be coming from posterior part, right? So the posterior vitreous cavity will have the inflammatory cells, right? So in all these cases, the vitreous cells or the inflammatory cells are going to look like dot echoes, and they will have low to medium reflectivity, right? So this low to medium reflectivity will be 10 to 60%. So whatever it is, differentiating it from the vitreous hemorrhage actually depends upon the history and the clinical picture. So if there's a patient who has signs and symptoms of uveitis, okay, has more pain, so we have to think in terms of vitritis or vitreous cells, right? However, if a patient gives you a history of trauma and the signs of inflammation are not present, patient is actually a case of diabetes mellitus or diabetic retinopathy, okay, or he's an old patient who's actually having on fundus examination a CNVM, then you might think in terms of the vitreous hemorrhage. However, in a case of uveitis, you might want to think in terms of the vitreous cells. So this picture over here actually shows the presence of vitreous cells which are present in the posterior vitreous cavity. Now in the first picture here, you can see over here is a dropped nucleus or the dropped lens in this person, okay, and in such a case, when the nucleus or the lens, the normal lens is dropped into the vitreous cavity, usually that lens is surrounded by the vitreous cells. So all the surrounding echoes that you see here, they reflect nothing but the vitreous cells. Now, one more differentiating point between the vitreous or the inflammatory cells and the vitreous hemorrhage is with respect to their evolution, right? So a vitreous cell or inflammation is going to evolve quite rapidly and form the vitreous membrane, and therefore whenever there is a case of endophthalmitis or there is inflammatory cells, the examinations have to be quite frequent because they can form membranes and cause tractions much earlier than the vitreous hemorrhage. A vitreous hemorrhage in which red blood cells are present, they are going to take their normal time and they're usually slower to evolve into membranes compared to the vitreous cells or the inflammatory cells. So that is also one differentiating point between the two. Now another thing is the asteroid hyalosis. Now as we all know that asteroid hyalosis is nothing but it is the presence of calcium crystals which are embedded in the amorphous matrix, right? So these calcium crystals which are embedded, okay, on B scans, they will actually look like multiple densely packed and they will be homogeneous in nature, right? And they're distributed dots of medium to high reflectivity. So what I mean to say is 50 to 100% can be the spikes. So just compare this over here. This is, so there are so many dots, almost all the dots are looking of equal reflectivities, and you can see, compare the reflectivity here. Almost all are reaching the spike of the retina, sclera and the choroid, which is about 100%. So highly reflective dots present in the vitreous with high reflectivity and with a zone of echolucency. So what I mean by the zone of echolucency is that posterior to the deposition of these calcium crystals in asteroid hyalosis, the zone of the vitreous is not showing any echoes. So that zone which is not showing any echoes is called the zone of echolucency. So here also you can see this is the asteroid hyalosis, and behind that we do not have any echoes, right? So this period, this part over here, there are no echoes, and this is called the zone of echolucency, and this is asteroid hyalosis. Okay, now one more thing is this picture over here is nothing but the vitreous hemorrhage. You can see this is a diffuse vitreous hemorrhage, but over here are certain cystic spaces. This is vitreous hemorrhage with lacunae. Next, something which can look very similar to that of our asteroid hyalosis is the residual silicone oil. Now we can all easily recognize an eye which has the silicone oil, because in that the eyeball will look more larger in color, larger in size and shape, because of the slow speed of the sound waves in the silicone oil. However, when we remove silicone oil, when we do a silicone oil removal, sometimes little bit of it might be remaining in the vitreous cavity, and then the reflections that we get is like this. Okay, and they will look very similar to that of our asteroid hyalosis. However, the difference is that there is no zone of echolucency. It is present all throughout. Give history of silicone oil removal or any history of vitreoretinal surgery in which the silicone oil was used. Now next, very similar a similar condition is the endophthalmitis, right? So it could be any type of endophthalmitis, endogenous, exogenous, traumatic or post-surgical iatrogenic endophthalmitis. In all these things also we will see exudates, or we can see vitreous cells. So as can be seen in this picture, it looks very similar to that of our vitreous hemorrhage, right? However, what gives us the clue is the history. Okay, so the first thing is history. However, so patient will give either history of trauma or penetrating trauma or any surgery, VR surgery or cataract extraction, and or the patient will actually be immunocompromised with some systemic illness, which tells you there might be an endogenous endophthalmitis in this patient. And on clinical examination, you might see a hypopion, a CCC, that is circumciliary congestion, all the features suggestive of endophthalmitis. And on B scan, typically one sign that you have to see is the elongation or the expansion of the choroid. Okay, so what is it called? It is called choroidal expansion or thickening of the choroid. So on B scan, one feature, if you have to remember with respect to endophthalmitis, is the thickening of the choroidal layer, right? Similarly, in this picture also you can see some membrane dots coming, you can see some dot echoes, right? However, what is more clear over here is the choroidal expansion or choroidal thickening, and this will tell you that this is a case of endophthalmitis. Now, in a case of endophthalmitis also, frequent B scans are advised because it can also progress really fast. Now, once you have seen a case of endophthalmitis and you have diagnosed it as endophthalmitis, it is very important to see the subtenon space also, right? The subtenon space is nothing but beyond the sclera there is Tenon's capsule, okay, which is enclosing the optic nerve also. So this below the subtenon's capsule or the tenons is the subtenon space. So whenever the infection will reach from the eyeball, from the chambers of the eye, which is endophthalmitis, and goes and involves the layers of the eyeball, that is the sclera and all, what will happen is, because of the infection and because of the exudation, the fluid will get collected into this subtenon space, and this collection of the fluid in the subtenon space will look basically black in color, or it will look echolucent area. And moreover, over here we have the echolucent optic nerve shadow, which is already present. So all these three echolucent structures will make it look like a T, okay, as if a T is written, right? So this is called the T sign, okay, and this indicates that there is a involvement of the posterior part of the coats, okay, the posterior coats are also involved